you for the invitation to speak. Today I'm going to tell you a little bit about the work that we and others have been doing to try and understand the role of inflammation in scar formation in the skin. So we all know that there are different phases of wound healing, at least in mature skin. The repair process typically begins with an inflammatory phase, followed by a proliferative phase, which then leads to the formation of scar formation. So collagen is deposited, as well as other extracellular matrix molecules, and then those ECM molecules are remodeled to form mature scar formation, mature scar tissue. And if you think about the outcomes of this process that you might see, typically you would see a repair process, which is indicative of fibrotic healing, and usually a normal scar will form. But on the other hand, you can see abnormal scarring result from the repair process. This would include things like hypertrophic scars, keloids, or contractures, where you have either an excessive amount of scar tissue formation or severely abnormal scar formation. And then on the other end of the spectrum, what we would like to happen in response to injury is regeneration. So that would be a scarless process whereby the wounds heal with basically by regenerating normal tissue in the area of the wound. And this actually occurs in fetal skin at certain time points during development. And so that's what our lab is primarily interested in, understanding this process of scarless healing in fetal skin. So in comparison to the stages of healing that I just spoke about, what you would see in mature skin, where you have inflammation, proliferation, and scar formation. In the fetus, this process looks a little bit different. You really have no or very little inflammation. You have a modified proliferative phase, so the wounds heal much more quickly. The cells are proliferating more rapidly, and the wound is able to close very quickly. And then the fibroblasts are able to lay down very normal looking collagen and regenerate, and hair follicles and other structures in the skin are regenerated. So these wounds tend to heal without a scar. This type of healing occurs during the first and second trimesters of development in a human. Our lab uses a mouse model to study this process. And so in a mouse, this type of regenerative scarless healing occurs from about 0 to 15 days of gestation. Then around embryonic day 16 or E16 in a mouse embryo, there's a transition period where the skin starts to heal more like mature skin would. And so beyond this transition period, the wounds, the skin, if injured, will heal with your typical repair process. So that's a fibrotic process that leads to the formation of scar tissue. And I just wanted to mention that you also see this in human fetal skin. And in this case, the transition occurs at around 24 weeks of gestation. So if you wound the skin at embryonic day 15, which is within this window of regenerative healing, and wait 7 days for that wound to heal, you have what looks like normal skin. So you see hair follicles here that have regenerated and no signs of scarring. If you wound just a few days later, beyond that transition period, the wounds will heal with typical scar formation. So this is a trichrome stain where the collagen is blue. So you see this area here of blue collagen where hair follicles and other appendages have not regenerated. So that's sort of a typical type of scar that you would see after injury in mature skin, as well as late gestation fetal skin. So one of the main differences in these two types of healing in fetal skin is that there's very little inflammation in the regenerative or scarless wounds, whereas there's a robust inflammatory response in the fibrotic wounds. And so obviously we think then that inflammation is important for scar formation. So how important is it, or why do we think inflammation is important for in regulating scar formation? So one sort of line of evidence that we have that inflammation is important is just what I just mentioned. Essentially, there's no typical inflammatory response in those early gestation fetal wounds that heal without a scar. And there's a lot of inflammation in skin wounds that heal with a scar. Secondly, we know that if you artificially induce inflammation in the wounds, in the scarless early gestation wounds that would typically heal scarlessly, if you induce inflammation in those wounds, they tend to heal with the typical fibrotic scar formation response. And then finally, we know that if you reduce inflammation, either in late gestation fetal wounds that heal with a scar normally, or in mature skin wounds that typically heal with a scar, if you reduce inflammation in those wounds, they tend to heal with less scarring. We don't usually see cases where we can completely eliminate scar formation, but we can get a lot less fibrosis and a lot less scar formation by reducing the overall inflammation levels. So I just want to go through and show you some examples of these from our work, as well as some others. So first, we know that inflammation is lower or even non-existent in some cases in scarless wounds. This is in part due to differences in regulatory molecules. So those early gestation fetal wounds that heal without a scar have a different cytokine and mediator profile. So studies have shown that there is high expression of anti-inflammatory cytokines like IL-10 in scarless wounds, and there's low expression of pro-inflammatory mediators, cytokines, lipids, or prostaglandins, as well as alarmins, which are pro-inflammatory mediators that sort of alert the body to damage. So they're released when there is damage in the tissue, and these molecules cause inflammation. So I listed two examples here, HMGB1 and IL-33 are examples of alarmins. And so from our work, we know that alarmins are upregulated in scar-forming wounds. And I'm showing one example here of IL-33. So if you look at IL-33 by immunohistochemistry, if you look at those early gestation wounds that heal without a scar, there's very little. You just see a few cells here that are expressing IL-33. You see much more IL-33 expression in E18 wounds, the wounds that heal with a scar. And then this is just the quantification here showing that E18 scar-forming wounds have much higher levels of IL-33. The other thing we know is that there are differences in inflammatory cells. So in scarless, early gestation scarless wounds, you typically see reduced numbers or reduced activation of inflammatory cells. And that includes neutrophils, macrophages, as well as mast cells. So this is work from our lab showing looking at mast cells. So this is a toluidine blue stain, which stains the granules of mast cells blue. And this is an E15 wound, the Scarless, the wounds that heal scarlessly. And you see that the mast cells are retaining their granules. They're not becoming activated even after injury in E15 skin. But in E18 skin wounds, you see a lot of mast cell degranulation in the area of injury. So these mast cells have now released those granules, which are these tiny blue dots here. Those are granules that are now in the extracellular space, and that's a sign of mast cell degranulation or activation. So there's more inflammatory cell activation in E18 wounds that heal with a scar. Secondly, I mentioned that if we induce inflammation in those early gestation fetal wounds, that typically will result in scar formation. And that's been done by injecting things like bacteria, chemicals, cytokines, growth factors, lipids, or alarmins, all things that induce inflammation artificially in E15 wounds, and that will ultimately lead to scar formation. And so this is one example here. This is a control wound that's been injected with PBS at E15. So we injected PBS into the wound, and you see that it heals very nicely with no scar formation, as you would expect if you injure the skin at this time point. If you inject HMGB1 into those wounds, which induces inflammation, you see the scar formation of a scar in those wounds. Okay. So this is just 2 different doses of HMGB1 that we've injected here. So if you induce inflammation, then you see healing with a scar. And then finally, we know that if you reduce inflammation, that you also tend to reduce scar formation. So you can do this by targeting inflammatory mediator production. This is an example of a study that we did where we treated wounds with celecoxib, which is a COX-2 inhibitor, and that prevents the formation of prostaglandins, such as prostaglandin E2. So you're reducing inflammation in those wounds, and this is immunostaining for LY6G, which is used as a neutrophil marker. So in control wounds, you see there's significant neutrophil infiltration into the wound. But if you treat the wounds with celecoxib, you reduce the number of neutrophils present. And if you look at the scars that form from these wounds, you see a significant reduction in the size of the scars that form when you reduce inflammation with celecoxib treatment. Okay. And then finally, we know that if you target inflammatory cells, you can also reduce scar formation. So there are numerous studies that have shown that if you reduce neutrophil infiltration, or reduce the number of macrophages, or reduce mast cells, or inhibit mast cell activation, that there is typically less collagen production and less scar formation. So this is an example of a study that we did looking at mast cell deficient mice. So this is actually an E18 fetal wound. So remember, those E18 wounds will heal with a scar normally. And this is a wild type mouse. So this mouse has mast cells. So you see a nice scar forming here. And then if you wound at the same time point in mast cell deficient mice, you see a reduction in scar formation. So I think I've shown you several examples, but the general conclusion here is that inflammation determines healing outcomes. And the more inflammation that you have, the more scar formation typically results from an injury. So you have very little inflammation in wounds that heal by regeneration or wounds that heal scarlessly. And then as the levels of inflammation increase, the amount of scar formation will typically increase as well. So we think that inflammation is really important for driving scar formation. And so our goal really is to either be able to reduce inflammation in human wounds to reduce scar formation, or optimize the inflammatory response. So I've been sort of speaking in general terms, but obviously you need some inflammation to help prevent infection. And so, you know, completely eliminating inflammation isn't necessarily a great option, but we can reduce inflammation or perhaps optimize the inflammatory response. You know, try to target very specific inflammatory cell types, for example, to try to reduce scar formation. So our goal really is to take fibrotic wounds and by controlling inflammation, be able to convert those into scarless wounds, the type of wounds that you would see during early fetal gestation or fetal development. So I'll stop there. I just want to acknowledge some of the people that have been involved in the work that I showed today. Brian Wolf was the main person in my lab that worked on the fetal wound healing studies, along with some other people in the lab. And then I've worked in the past with other people at Ohio State to develop the fetal wound healing model, and some people at Ohio State in some other areas like biostatistics as well. So I guess I can answer any questions, or we can have a discussion based on what I showed.
Dr. Wilgus, thank you so much.
Sure.
I think your research, it's so helpful for our research too, because most of our students or our colleagues are very interested in the scar forming and how to reduce the scars. And yeah, and now we have the discussion time. Do our guests or other doctors have any questions? And we have a discussion. Yeah, Dr. Elia.
Thank you very much. Great, great presentation. How do you have any data or any information about the effect of radiation on scarring?
No, we do not work in that area. I know that there are some people developing models to look at radiation injury and, you know, how that changes the healing process, and you know, radiation can be a stimulus for fibrosis, obviously. So there are a lot of people looking into ways to alter that process, the response to radiation injury, so that you can reduce fibrosis. But that's not something that we specifically look at. But yeah, that's a good question.
Yeah. I'm sorry. Well, I have because it's very interesting that you about the timing of your of this webinar and your presentation. I do have a patient right now who has a horrible keloid retroauriculary. You showed a photograph of a case like this, and we are actually after we resected the keloid, we are waiting for the result after radiation that happened a couple of hours after operation. And the other thing we're working with, of course, is silicone with scarring. But we don't know how it really works, or if it is mechanic or biochemical in any sense.
Yeah, I mean, I think there are a couple mechanisms that have been proposed for silicone, and I know that Tom Musto's group has been looking a lot at that for years, actually, and they think maintaining hydration actually alters the ability of keratinocytes to stimulate fibroblasts. So that's one sort of mechanism. The other thing I mean, keloids are really tough to treat, and but there's work from Stanford, a group at Stanford, Jeff Gertner and Mike Longaker, who have shown that mechanical stimulation is really important for controlling scar formation. So they actually have a bandage that's on the market here in the US. I'm not sure if it is in other places, but essentially they've created this bandage that reduces the amount of tension on the wound, and that tends to reduce scar formation. I haven't seen any studies that have looked specifically at preventing keloid recurrence, but there are a lot of studies in sort of linear incisional wounds that show reduced scarring when you treat with that bandage, when you sort of offload the tension in the wounds. But yeah, it's keloids are very difficult. Yeah.
Yeah, and Dr. Wilgus. Yeah, there were several stages of this of the wound healing: the inflammation and proliferation, and the remodeling. So I'm wondering if the inflammation, this stage, is inevitable to initiate the proliferation. If we, for example, we have reduced the numbers of the inflammatory cells, or we depressed the inflammatory reaction, if it's a problem, or is it difficult to initiate the stage of proliferation?
Yeah. That's a good question. There are evidence in animal models that it's hard to completely eliminate inflammation in mature skin, but you can significantly reduce inflammation without delaying healing in the absence of infection. If you add infection into the mix, then it's a different story. But it's very interesting, right? Because people generally think that inflammation is needed to jumpstart that proliferation process, that proliferative phase. At least in fetal wounds, that doesn't seem to be the case. And it could be that fetal cells are inherently more proliferative to begin with, and so they just respond more quickly to injury, and you wouldn't need the growth factors or the cytokines that are produced by the inflammatory cells to promote proliferation of those fetal cells. But that's a very good question, and we don't have a great answer. What I would say is that inflammation may be important. for stimulating those other phases, but I think it's not as important as we once believed it was. I guess that's what I would say. I think there are other mediators produced when cells are injured, perhaps, that can stimulate proliferation of cells without necessarily needing as much inflammation as we once thought we needed to start the process of repair.
And we doctors, especially the clinical doctors, we may have such experience that if the patient are using the corticosteroid, and it will impede, say, a smooth wound healing.
Yeah, and that's a good point. And I think you need a balance, right? So if you can reduce inflammation enough to reduce scar formation without negatively impacting the repair process or wound closure, I think that would be ideal. And the other thing is, I think for certain types of wounds, you might want to, you might be able to get away with delayed healing if you have less scar formation in the end. So I sort of come at the wound healing field from a cancer background. And so if you think of someone that has a skin cancer lesion on their face, for example, and they have to have surgery to remove that lesion, someone like that might be willing to sort of sacrifice delayed a little and have a little bit of a delay in healing if the outcome in terms of scar formation is going to be better. But obviously, if you have someone, with underlying diabetes that's at risk for an ulcer, a diabetic foot ulcer or something like that, if you're thinking about that type of wound, then it's a little bit different story, and quick wound closure would be your primary concern, right?
So your research really encouraged me to my student to continue this research. That I try to tell them, okay, you may make incision of the mouth and try to apply something. For example, mesenchymal stem cells or the supernatants of the cells to say fresh wounds. I want to see how it will influence the scar or the healing process or the scarring process.
Yeah.
Thank you.
Sure.
And Dr. Elias, a quick question.
Hold on, yeah. Do you think angiogenesis is a possible target for scarring or against scarring?
I do, actually. We've done a lot of work on VEGF. I didn't show any of this today, but if you neutralize VEGF in experimental wounds, of course, and reduce the level of angiogenesis, you can actually, the wounds tend to heal with less scar formation, which is a little bit counterintuitive when I talk to clinicians especially. But the reason we think that might be beneficial is because when the wound is healing, you have sort of an overproduction of blood vessels that aren't necessarily functional. And so we think that you can sort of prune the non-functional vessels and actually perhaps get better perfusion. So essentially, when we neutralized VEGF, we didn't see any sort of delays in healing, but we saw reduced scar formation. Now, obviously, you wouldn't want to completely eliminate angiogenesis. You need some blood vessels to deliver oxygen and nutrients to the wound. But we think, again, by refining that process, and you want to stimulate functional vessel formation versus this sort of chaotic, inflammatory, leaky vessel type of situation that you have in an acute wound. You may be able to do that by targeting something like VEGF, or at least knocking down the levels a little bit so that you get more functional vasculature forming. You may be able to then reduce scar formation.
Very interesting. Thank you.
Yeah.
Yeah, thank you so much. And let's start the second speech. Is that okay?